talk about the term tongue-tied, you're actually referring to the frenulum, which is the piece of tissue underneath the tongue that holds the tongue to the floor of the mouth. The frenulum can be too short, too tight, located too close to the tip of the tongue, or located too close to the rear of the tongue underneath. When this happens, it gives the tongue what you call a restricted range of motion. Therefore, it affects how well the tongue extends, how well it lifts, how well it lateralizes, how well it performs what's called peristalsis, which is a wave-like motion that the tongue does underneath the breast during breastfeeding, as well as how well the mouth gets a tight seal on the breast during breastfeeding. There are several ways to go about determining if this baby is actually tongue-tied, and if this baby's tongue-tied is a candidate for what's called a frenotomy. And a frenotomy is like taking a small little tight rubber band that has no slack to it, taking small scissors, giving it a little nick, therefore the tongue has just a little bit more range of motion. Now, if you were looking at the Cutlow diagnostic for tongue-tie, he breaks it down into type 1, type 2, type 3, type 4. Type 1 is located right at the tip of the tongue. Type 2 is located midline underneath the tongue. Type 3 is distal to the midline, a little further back. And type 4 is all the way to the back of the tongue underneath, and it's called a posterior tongue tie. Hazel Baker uses different areas of function and appearance and scores each area separately to come up with a number that determines whether or not this tongue would be considered a candidate for a frenotomy, or whether or not you would call this a tongue tie. Now, type 1 tongue tie, because it's right at the tip of the tongue, because it's very easy to see, it's more than likely to be diagnosed, and therefore more than likely to receive a frenotomy. Type 2, 3, and 4 are harder to see, harder to get a diagnosis, and less likely to receive a frenotomy. Therefore, it's important that a mother with a baby who has a tongue tie may have to learn to breastfeed with something that won't be fixed. At birth, a tongue tie is a breastfeeding issue, can very possibly turn into a speech impairment called a lisp. At 2 years old, though, it's not likely to be fixed, because it's actually really cute when 2-year-olds talk like this. And usually a doctor will say, let's wait a little while and see what happens. At 4 years old, if the lisp has not improved, this child may then be recommended for speech therapy for a couple of years. At 6 or 7 years old, if speech therapy has not improved the situation, the dentist may choose to revisit the idea of a tongue tie at that time. If it doesn't happen at 6 or 7 years old, in the teen years or possibly the young adult years, a person may be doing what's called tongue thrusting and pushing their tongue against their bottom teeth. That causes the teeth to spread. It's called myocclusion. And for those reasons, again, a doctor or a dentist may decide to revisit the idea of a frenotomy at that age. However, there are a lot of adults with tongue ties that have never been fixed, so it's not always a candidate for repair. Therefore, like I mentioned, we want to be able to work with something that won't be fixed, because mom still needs to breastfeed regardless of what level of tongue tie this baby is dealing with.